My name is Fernando Lopez-Rios. I am a pathologist based in Madrid, Spain. And I'm going to talk to you today about a feasibility study of rapid lung next generation sequencing testing, which was supported by an Oncomine clinical research grant. So first of all, I would like to thank Thermo Fisher for this opportunity and also for the invitation to be here today. My disclosures. And this is the content of my talk. First, I'd like to start by a brief introduction, trying to answer the question, what is the best way to deliver biomarker information? And then I will address one of the clinical practice gaps, which is turnaround time. And I will finish by showing you some of the results of this study, of this trial, a look into the future, ultra-fast NGS. Is this possible or not? And hopefully at the end, I will convince you that this is a good opportunity to make sure that all of our patients with advanced and now also early stage lung cancer have a fast and reliable NGS result. So what is the best way to deliver biomarker information? The short answer is as soon as possible. I was very impressed when I saw this data that was released last ASCO. And as you can see there, if patients receive incomplete testing, overall survival is only 11 months. But if we're able to provide comprehensive testing, overall survival, it's almost 2 years, 22 months. This probably is something that it's very obvious, and we already knew this. But here is where it gets interesting. If these results are available before the beginning of first-line therapy, overall survival is 4 times more. So we go from only 6 months all the way to more than 2 years, more than 24 months. So we need to be able to provide comprehensive testing before the beginning of first-line therapy. And that's why we really have to work in a very efficient and a very fast manner. And if we try to provide all these biomarkers for patients with non-small cell lung cancer, probably the only way to do this is by using next generation sequencing. As you can see there in that Venn diagram, we have to look for mutations, we have to look for copy number variations, and we have to look for translocations, fusions. And some of them are present in a very low frequency, in frequencies that are around less than 5%. Now we also have to be very precise when we diagnose KRAS mutations, because some of them are now actionable. For example, KRAS G12C. And the same holds true for EGFR mutations that now we have, for example, EGFR exon 20 insertions that are a subgroup of actionable EGFR mutations. And to identify those, we need NGS. So complex because there's a variety of methods, and also because some of the actionable alterations are not very frequent. And if we try to address clinical practice gaps, it's useful to have this data and to review this data, because as you can see there, this was released in the US, 500,000 patients, and almost 50% of those were lost to precision oncology because of factors associated with biomarker test results. So if you summarize those gaps, it is probably not having access to tissue or tissue being insufficient for biomarker testing, Also, maybe not choosing the right assay for all those complex alterations that we now need to identify. Having results after therapy has been initiated, so turnaround time, very important. And finally, of course, cost. So I'm going to focus on turnaround time because I think it's something that we can solve by the use of some of these new sequencers and also robotics in the extraction phase of the procedure. What's happening now? Because if we think of turnaround time, maybe we tend to think that 2 weeks is fast enough. So I was really intrigued when I saw this data. In the first column, results without the use of lean workflows and before implementing reflex testing. So as you can see there in the first line, days from the pathology report to the NGS report is more than 3 weeks, 24 days. And if we use better workflows, we can maybe be close to 2 weeks, 10 working days. This is what most guidelines recommend. But can we do better? So that was our hypothesis, ultra-fast NGS. So the way I see this is trying to close the gap between real-time PCR and NGS. And why not dreaming of a same-day result in the very near future? So in the past few months, in parallel to our clinical NGS workflows, which take a bit longer because we have a busy practice over here, we've tried to organize an ultra-fast workflow, which starts on Thursday by the identification of the slots, and we consensuate patients with the clinical team. Then on Friday is where DNA and RNA extraction takes place, and we do that sequencing part, libraries, templates, sequencing. We use the weekend, which is sometimes kind of a lost time of the week in terms of providing for our patients. And finally, very early on Monday morning, we analyze results, we concentrate results first with the team in the lab, and then we sign out those NGS reports and eventually discuss the results with oncologists. So that should be 72-hour turnaround time. And here are some of the results of the first 40% of the study, which I think reflects what we most labs have in real world. For example, 70% of our patients had adenocarcinomas, and 80% of those were in advanced stage, and over half of our patients were former smokers. So I think this probably reflects what we have in many regions across the globe. This is the assay that we've been using, the Oncomine Comprehensive Assay version 3. As you can see, we have hotspot genes, full-length genes. Also, we are able to identify copy number variations in many of those genes, and of course, fusions that are now very important in patients with lung cancer. In terms of sample types, I was very pleased because all sample types so far were optimal. It's true, we have a very stringent philosophy. So we try not to use samples that we know are not going to give us robust results, because after all, the treatment of patients might be delayed. So we do have more than 50% of those samples in the form of corneal biopsies. We also have some surgical specimens, of course, small biopsies, and even cytology specimens, which were transformed into cell blocks. And here are the results, the initial results, which are not the exact frequency of some of these alterations that you would expect in my country, at least. For example, we have a very high rate of EGFR mutations because we have a lot of clinical selection in terms of access to clinical trials, etc. I think the same holds true for ALK fusions, because we are sometimes very focused on the search for these fusions. We also found some patients with MET exon 14 mutations, of course, BRAF mutations, KRAS G12C, and probably the frequency of other KRAS mutations is within the expected frequency. And I'm going to just show you very briefly the results of one of these patients, so you can get a feeling of how we do things. So this patient was a male, 77 years old, never smoker. So very important to always consider smoking history, which I think sometimes is neglected in when we try to integrate clinical findings with histology and with the genomic findings. This patient had a lung nodule in the upper right lobule, 20 millimeters in size. So a core needle biopsy was performed. And if you have some time, please do scan this code with your cell phones, because hopefully it will take you to a whole slide imaging of that patient's core needle biopsy. While you do that, I'll take a moment to emphasize how important it is to try to use digital pathology as the backbone, as the workflow decision maker when you are trying to implement not only next generation sequencing, but also ultra fast next generation sequencing, because that way you can select what's the best paraffin block for that particular assay, and you don't waste any time running around with a glass slide. And so I also took some images in case you were not able to access that whole slide imaging. As you can see there, the patient was diagnosed with an adenocarcinoma that contained signaling cells, as you can see there in the arrows. This is a very good predictor for the presence of an actionable fusion, and we need to be more persistent when we see this finding. In this case, it was not necessary because we were able to identify one of the typical ALK fusions, EML4 ALK, with variant 1. So we were very happy because this is an actionable finding. So in conclusion, I think now we are facing a new situation in patients with lung cancer, as you can see there in this figure, because we have to make sure that all of our patients with lung cancer have a precise histological diagnosis.
Right. I hope you can hear me well.
Yes, very well. Thank you.
Thank you very much for joining us today. And again, thanks for your presentation. I know we only have a very short Q&A session for today, as also you have to keep going. There's a number of questions from the audience. I will only pick one for today, and it's actually about the type of samples that you have analyzed. You showed very, very substantial and concrete, tangible result. The question is, can you really apply that also to samples with very like cytological spacement?
Yes, Luca, this is a great question. Absolutely. We are in fact now trying to optimize the procedure for more types of cytological samples. But having said that, I always recommend trying to obtain a cell block, because it's like a very small biopsy. And then if you do need to do something else, PDL1, of course, or maybe validate something, you have more options. You have an alternative. So if at all possible, I think it's good to have smears or to have your regular cytological workflow, but always make sure that you try to obtain a cell block. And as you know, what we are really pleased is that the assay requires very little DNA and RNA input, and this is wonderful because if you're a little careful and you communicate effectively with your colleagues in the surgical and cytopathology section and department, you are most of the time able to carry on with your NGS workflow.
Fernando, thank you very much for that. There's one very last question as we are at time, and it's about some of the data that you have shown about survival, and especially the absolute outstanding difference between having the result before first-line treatment or having them afterwards. This study was presented also last year at ASCO. It was a lot of excitement around this one. Do you plan to perform something similar with your own prospective result?
Well, we would love to. I mean, this is just now a pilot. It's a first step, making sure that this is doable with the resources that we have. But of course, I mean, we have to take this one step further and actually, try to demonstrate that this is going to impact the way we treat our patients. And also, we need to always consider patient-centered approaches. So I think it's very, very important also to ask them, to involve them, and I mean, whenever we ask them, that they always prefer to have the results as fast as possible. So that's I know that's very obvious, but it is always important to consider, to have a patient-centered approach. I think the anxiety that a patient has waiting for a result can now be minimized if we have a better coordination with the help of these approaches.
All right. Well, Fernando, maybe if we can squeeze one more, because there's a number of them, and I will put all of them together. All those questions asking the very same thing. With the ultra-fast NGS, as you have demonstrated with your study, is it really now there is still a case for using liquid biopsy? Because liquid biopsy was also tried to be pushed in a way as it's faster than tissue and you can save time. Is this still really an argument, or the argument for using liquid biopsy, it's no longer about time, but it's about something else?
I think it's no longer about time, it's about something else. But why not an ultra-fast liquid biopsy? I think I'm going to answer the question by asking another one. But now that you mentioned this, I think the first thing the clinical team told us is like, oh, you are faster than the liquid biopsies results. But I answered. We told them, well, then we should do better with liquid biopsy. So I think it's not about tissue or plasma. I think it's just trying to provide for our patients and be as comprehensive and as fast as we can. So thank you for this opportunity, because really I think this is what we need. We need to really close the gap in the turnaround time, at least challenge.
All right. Well, Fernando, again, thank you very much for being with us today, for your fantastic presentation and for your flexibility on time. I'll let you go, enjoy the Congress, and I'll talk to you very soon.
Okay, thank you very much. Cheers. Bye-bye.
Thank you. Bye. Cheers.